Walk over there.
Two comments. First one will be Dr. Radke. Excellent. I really appreciate that. That will be very valuable for us to have in our ORs for teaching people. I'd encourage you to put that video up on surgery use so we could disseminate it across the AAGL universe. The second one is for Dr. Hernandez-Lopez. That's fascinating. That's an interesting case report. And I'm thinking out loud here, do we have a registry beginning in AAGL where people could find interesting case reports for rare events to try to begin to collect the data that you're talking about? That thing is so uncommon, you're not going to be able, you may never see another one in your practice. Our way you'll see maybe in a big place like Europe, maybe one every 3 or 4 years. But I wonder if AAGL we could set up a registry for case reports to begin studying things like that.
I've actually got a follow-up question for Dr. Hernandez while we're there. Dr. Hernandez, we know there's radiofrequency ablation with the Sonata study for fibroids that's trained surgical. On this device, as far as thermal spread in the ablation zone and the duration, how is it that you calculated it as far as how the ablation time in the ablation zone? Because there's not a visual feedback, and knowing that cesarean scarring topics are close to the bladder, was there any concern for inadvertent thermal injury to the bladder?
You have to go over there, please.
Here. Y'all here. Yeah, that's okay.
Oh, come here.
So the IR department had actually run the simulations, I believe, based on prior data that had been collected in like animal studies using, I believe, bovine to sort of create these predictable spherical volumes that we then used for this patient in her case within the uterine tissue. But yes, the proximity to the bladder was definitely something that was of concern, and so per their comfort level, they were saying that if this is another case for future patient, at least ensuring 5 millimeters of distance between the bladder and the pregnancy would be ideal.
I have an additional question to that. Don't you think it would be advisable to add laparoscopy to see if there's a stitch necessary? Because I think the taking out is fine, but how do you have a prophylaxis for a future defect, a future ectopic pregnancy in that lesion?
Yeah, I think that's definitely a very good point that you're bringing up. Is we don't know, we don't have enough data to say how this may impact future pregnancies. And from what I had heard, there was another talk here where they were talking about exactly what you're saying. Placing a stitch or reapproximating that tissue so that there's a lower chance of that happening in a future pregnancy. I think that's a wonderful idea.
I'd like to congratulate all presenters. It was really great presentations and a very innovative approach that you guys were able to put into practice. That's really great. I did have a question for Dr. Braxton. I think there's a very nice studies that you did, and it helped with the delivery of healthcare. I noticed that some of the patients did not have physical examinations before being taken to the operating room. And I was wondering whether you had certain firm criteria, how you selected those patients. And also, I wanted to know whether you had any problems with like pre-approving surgeries, whether you think there was any issues with liability based on the fact that you take patient to the OR without ever examining the patient.
That's a great question, and particularly, so I'm going to kind of divide that into both of the preoperative visit study as well as our new patient consultation study. With the preoperative visit, fortunately, we've already seen those patients in person. For the under that scenario, we saw the patient for an in-person consultation, and then half of them had the virtual visit for their pre-op visit. And for our standard practice, most of our preoperative visit is counseling anyways, and we're not necessarily having to repeat an exam. So, but for the new patient consultation performed virtually, most patients did actually come back for an in-office visit before scheduling them for surgery. But we did have a few who they were certain, and based off of their medical history and you get so much from just talking to them. And so based off of what we had in the EMR and what we had available to us, we were able to go ahead and actually book those patients for surgery and evaluate them in the preoperative area. So yes, that didn't happen all the time, but there were a few cases where that did happen. And it was mainly patients who were, young, healthy, didn't have any other medical comorbidities. But yeah.
I have a question for her.
Absolutely, thank you. Thanks for your question.
Dr. Braxton,
Yes.
one more question for you. Matt Lindemann, I'm from Anchorage, Alaska.
Oh, wonderful.
So that telemedicine, we've been doing more and more that is especially useful for Alaska because it's
Yes.
so huge. Question is, if the patients call from another state, what do you do with that? 'Cause
That is
isn't-
a great question. And there is a lot of regulation, as we've all kind of learned throughout this pandemic process. Before the pandemic, before the emergency waiver was in place, patients had to physically be in the state of North Carolina, which is unfortunate for us because we're right on the border. Charlotte's right on the border with South Carolina, so we have a lot of patients who are in South Carolina. And so, if there's one positive about the pandemic for this situation, it was that emergency waiver allowed us to actually kind of expand and be able to see those patients. They didn't have to drive across the border to sit there on their phone and do their telehealth visit. So that was very helpful for us. I don't know what is going to happen with that when the emergency waiver goes away. The Centers for Connected Health and Policy is a great website, and they keep everything up to date and give you specifics about your specific state. And there are certain states that do have reciprocity, and then others that don't, and it's just very convoluted and confusing. So I highly recommend that website for
What's it called again?
It's the Center for Connected Health Policy, CCHP. Yeah.
Okay, my question is for Dr. Cope. So in my training and in my current practice, no one that I've trained with and none of my colleagues have done the intra-arterial ICG injection. So my question is it something that is routinely done where you are? And if it is, what complications have you seen with it?
That's a great question, and I think that we tend to use it more for anticipated advanced endometriosis cases. That tends to be the place where we use it the most, and we actually started using it more in our practice because for those cases with bowel invasive disease, we tend to partner with colon and rectal surgery or gynecologic oncology, and per their preference, they use it routinely for their bowel work when they're doing robotic low anterior resections, and so that's where we kind of started using it. Since then, we've adopted it a bit more within our own practice, and we, knock on all of the things, haven't had any complications with this so far. I think that, as I talked about in the video, that it's comparable to ureteral stents with some caveats that make it a little bit more favorable in terms of diameter and risk of injury just from instrumentation of the ureters. It lasts for the duration of the case, even with our long cases last 6 to 8 hours, and so it's been useful for us in those advanced cases. We don't routinely use it for all, but especially if we anticipate that there could be something that makes it harder to see and we're concerned about safety and we're debating on stents, we tend to favor using the ICG just for those reasons.
So you just inject once at the beginning of the case, and then do you leave the catheters in, or do you pull them after the injection is done?
You can do either, and so you could place the ICG and then remove the catheters and just rely on the ICG for ureteral identification. If you're needing stents for a different reason, so say there's invasive disease in the ureters and you're going to be using the stents for that component of the case, you can inject on one side, go to the other side, inject that side, and then go back and put the catheters in, just to allow that time for the ICG to react with the tissues within the ureter.
But it's lasting long enough that you just inject and it lasts through the case?
Mm-hmm.
Okay.
Yep.
Thanks.
Can you please stay there?
Yeah.
I have actually a question more for our Dr. Kano, but we do not know if you can connect to him. That is the ICG, the ureter was very convincing, but the ICG and the immunofluorescence does not so convincing to me because everything was green. And so my question is actually for other applications than to show the ureter. I see Dr. Kano is coming. Are you really happy in nerve sparing surgery to see the nerves green?
Yes. As you mentioned, all tissue which are blood flow are highlighted by CG. So I use both white light image and fire light image to identify autonomic nerves and deep and muscular regions. And nerves, I presented non-brain sparing surgery, and non-brain referred to nerves and fat tissue and small vessel with surrounding fracture. And nerves were highlighted strongly by ICG image, but some experience is necessary, of course. I adjust the brightness and contrast of Firefly case by case.
And could you really see the endometriotic lesion being green?
Yes. Deep endometrial regions are hypovascular regions, so not highlighted by ICG.
Hypovascular ones are not highlighted.
Hypovascular region, deep endometrial regions, yeah. Almost include fibrosis, so not highlighted by ICG.
Thank you very much. It was nice to have you with us. Thank you both very much.
Thank you.
Thank you very much.
We may have time for one more question. Dr. Park, could you comment on the difference in the cost per case for the single site robotic surgery versus conventional robotic surgery?
Single site surgery 차이점. There is a convenience about. Hi, this is Dr. Moon. Yeah, I'm a colleague of the Professor Park. There is the difference between the single site robotic surgery and the single port robotic surgery is that robotic single port, when we perform the robotic single port surgery, we can use the curvature of the instrument, so we can assess the more deep space and
I think my question was more the comparison of the, not the OR times or the technique, but what the cost was per case. Did you all look at the difference in cost?
Cost is the more expensive more expensive when we perform the robotic single port surgery, because the Da Vinci SP system is more expensive and the instrument is, the cost of instrument is so high. So we the patient has to pay more, little more than when they receive the single site surgery. Is it the educated answer?
Yes, you did. I think having that cost analysis per case, if for future publication with this comparative trial, would be very useful. So.
Yes, thank you.
Then maybe I'll end up with a question to Dr. Radke, if you can come to the mic. Can you imagine that uterine manipulation can be done voice controlled? Because we can learn by augmented reality, but we need it intraoperatively voice controlled.
Correct. Yeah, there's been several products over the last decade, I guess, that particularly try to address that. There's one that I can remember in particular, I have no affiliations to, but Vaki Up was trying to be pushed for about 10 years ago. Again, voice controlled next to the robot, you could say up, down, left, right. The technology, unfortunately, was not there in order to be helpful. Like the little movements and very intricate, like pressure modulation that has to be performed. It's a human being at this point is probably.
But today it's there. What you're showing, how you're showing, it's there. The technology.
The technology is there, and now with the new, now Cooper Surgical bought that Ally robotic arm that Intuitive was developing, and now it's widely available, and that is helpful. Of course, a human still needs to adjust it. You need somebody to move it and then it holds it in position at least. But that's a start, because once we can add controls to that particular mechanic device, then I think that will, that will definitely solve that issue. Robotic surgery, I think that's one of the main problems. As a surgeon, we're not at the bedside. We can't correct somebody that's there that is an office. We're at the console. We're not even scrubbed in. So I think more technology development in that area is definitely required.
Okay, I think so. We've only managed to go a few minutes over. So I want to congratulate all the speakers on a great presentation, both those that were able to make it to Austin and those who presented virtually. Again, we apologize for Dr. Rosen for having the technical difficulties. Hopefully we can be able to see his slides virtually at some point. So thank you all for attending the session, and I hope you all have a wonderful rest of the meeting and safe travels.